Good morning, everyone. I would like to thank the organizing committee for inviting me to give this talk. My talk is on the tips and troubleshootings for the setup of robotic cancer surgery. So basically, it can be divided into two parts. So the first part will be on the troubles. So what are the troubles that we can encounter during the robotic cancer surgery? And then followed by how we can tackle the problems. Okay, so in order to understand what troubles that we may encounter, we have to know what surgeries that we will be performing for gynae cancers. So hysterectomy, either simple or radical hysterectomy may be performed, although nowadays we seldom perform radical hysterectomy for cervical cancer after the LET trials. Robotic trachelectomy may also be done. Lymph node biopsy, either pelvic or parietal lymphadenectomy, are also common robotic surgery. So sometimes we may also use robotic surgery to perform omentectomy, debulking, or even exenteration. So unlike general gynae surgery, well, of course, we will still need to deal with pelvic surgery, pelvic dissection, but sometimes we have to go deeper down into the deep pelvis or to the pelvic side wall, and we will also go upward to the upper abdomen when we perform parietic lymphadenectomy or omentectomy. So in terms of complications, there are different factors that may lead to risk factors that may lead to complications, just like pathways. So we may have a risk factor arising from the patients, either due to the age, medical morbidities, body size, or tumor size. Well, it can also be due to the operations itself because, for example, when we go to the deep pelvis, there may be lots of small vessels that may easily cause bleeding. And then, of course, the risk factors may also be related to the device itself. It can be arising from the physician cards, patient's card, or the surgeon console. And also medical teams. In fact, we've performed some studies and we found that about 20% of the complication may be arising from the operators. So this can be due to inadequate skills and knowledge, a lack of anticipations of the risk factors, and also miscommunication between different specialties. So all these will lead to some problems during, for example, patient positioning, pneumoperitoneum, port placements, and that may also lengthen the durations of operation, and that in turn will give rise to complications. So how we can deal with the troubles? So here I give you some examples that as an illustration. So first, small surface areas. It's not uncommon that Asian women will have small surface areas in the abdomen. And the potential troubles related to that will be clashes of robotic arms or instruments. It may also cause chopsticking inside the abdomen. And these sort of clashing, chopsticking may lead to interference organ damage. And also, because of the small surface area, there may not be enough room to place the assistant port. In fact, we've conducted a little survey a couple of years ago that included about 50 patients. And we look at the distance between different body landmarks. So the average body weight is about 60 kilograms. And the average BMI is about 24, so pretty standard. So this is here, E here. So you can see that some patients may have acute angle of just about 50 degrees, and then even after peritoneum, it's still less than 90. So you can imagine that if we have a small patient with such small surface area, it's quite difficult for us to put in the port. So this is a schematic diagram before and after the pneumoperitoneum. So what can we do here? So first, we can consider to place the port in the lower abdomen or lower pelvis, which I'll show you a diagram in a minute. And sometimes we may have to adopt a more triangular alignment because for a fat lady, we may put the port in the horizontal manner or at a slight 5 degrees to each other. But then for small patients, we have to adopt a triangular alignment. And rarely, we may have to use just 3 arms instead of 4 arms. And sometimes we have to consider changing the instrument during the operation where we encounter clashing. Very commonly, we have to swap the grasper and also the monopolar scissors. And if there's some clashing of the arms limiting our movement, we may have to manually adjust the robotic arms towards our new target. And sometimes we also need to undock the arms and reorientate the entire boom to perform the targeting again. So this is the lower abdomen. Well, obviously this patient is a bit big, but the principle is the same. So just imagine if the costal angle is very acute here, then we may not be able to put a port in the upper abdomen. So what we can consider is to place the port in the lower abdomen. So so this one is the diagram. So we put the camera port in the umbilicus, and then 4 other ports in the lower pelvis. So the scissors and also this one, we put it about 7 to 8 centimeter next to the midline. And then the grasper, which we use cardia, and also the bipolar is 7 to 8 centimeter next to the medial port. So this is how we perform the targeting to the pelvis when we perform hysterectomy, pelvic lymphadenectomy. So this is the configuration. If we have to perform upper abdomen dissection, for example, or mandectomy or para-aortic lymphadenectomy, we'll move the boom clockwise and then perform targeting again. So this time we'll target at the upper abdomen, and then we swap the instrument. So now this port, the right lower abdomen port, will become the camera port and the bipolar laterally. And then these 2 other ports on the left side of the patients will be scissors and also cardia. So my preference is to put this camera port to a bit lower down to the pelvis so that I can have broader pictures of the whole abdomen. And this one small dot red here is where we put the assistant port. The assistant port is ideally placed at least 7 centimeters away from the robotic port. And we try not to place it between the robotic port and the target anatomy. Otherwise, it will obscure the sight, and also the arms may hit our colleagues. And we have to ensure that the assistant is facing to the target anatomy. When we try to use longer instrument if possible, for example, we'll use a longer sucker so that there will be more room for our assistant to move. And the assistant ports that we are using is the air seal system. So air seal is a valveless choker where the instrument and gauze can be moved in and moved out easily. And it's in a double-barreled configuration so that the gas inside can be sucked out easily, where the neuroperitoneum can also be maintained. And another things that we have to pay attention is about the cannula insertion. We try not to put in too deep, because otherwise it will increase the friction, reduce the precision of movements, and in turn it will also increase tissue trauma. So just put it where we can just see the thin black line. And in that case, the range of movement may also be more beyond the abdomen. And if space is a concern, we'll try to utilize the patient clearance as much as possible so that the robotic arm can rotate axially clockwise away from the patient and also the other arm. So another situation that we may encounter is obesity, which is quite common among endometrial cancer patients. So sometimes they have a lot of visceral fat as well. So the potential troubles related to obesity will be patient positioning, pneumoperitoneum, and also the prolapsing bowel loops. So patient positioning can be a concern because if they are too big, the braces may cause brachial plexus palsy, pneumonal nerve palsy, and other nerve palsy as well. And in severe cases, it may also lead to compartment syndrome and rhabdomyolysis. And luckily, we seldom see these. And steep transdermal birth may also be a problem for obese patients because it can compromise the gaseous exchange, and it may also really lead to orbital pain, periorbital edema, and even visual loss. And it can also cause head contusion, subcutaneous ecchymosis, and laryngeal edema as well. And fat lady may not be able to stand for prolonged pneumoperitoneum because, again, the pneumoperitoneum can decrease the lung compliance and increase the plateau airway pressure. So those patients with BMI more than 30 will be at a higher risk compared with slimmer patients. So what we can do? So first, we try not to put the arms too widely because unlike the the S or SI model where the robotic arms are big, for XI model, there's no use to put the arms too wide apart because otherwise it can cause clashing between the cartridge and also the next robotic arm as I showed in this picture. And we have to try to shorten the duration of the steep transdermal position. So for example, if the patient have to have hysterectomy, pelvic and parietic lymphadenectomy, we may perform the parietic lymphadenectomy first with a steep transdermal position, and then after that we go back to perform the hysterectomy and pelvic lymphadenectomy, where the patient do not require such steep transdermal. So we have to swap the sequences of steps, but of course sometimes we may not be able to do so. And there are also some series suggesting that restrictive root replacement to less than 200 ml may be useful. And I've also seen some case reports saying that venipuncture may also be useful, but I'm sure nobody will do that. So effective team and good communications with our anesthetists will be useful. And also good knowledge and skills of the operation to shorten the durations of operation is also ideal. And the optimal timing or durations of operation should be less than 4 to 5 hours. For the pot placement, well, in fact, it doesn't really matter because there's a lot of room. So basically, the determining factor is what operation we have to perform. So if we have to perform just the lower abdominal, well, the pelvic lymphadenectomy and hysterectomy, we can just put in the pot in the lower part. But then if we have to perform upper abdominal dissection like parietic lymphadenectomy, sometimes we'll consider the lower pot placement as just I showed you for the thin patient, just the same. Another common situation is patient with big uterus. So this picture showed a diagram where we look at the abdomen from below to above. So this is the appendix, and the blue arrow is the fundus of the uterus. So you can imagine that the fundus of the uterus is already at almost above the pelvic rim. So the problems related to big uterus is the uterus may obstruct the veil. That may cause organ damage, and it also lead to the problem when we retrieve the specimens, i.e. the uterus. So what can we do? So first, we have to move the camera to above the umbilicus so that we can have a broader view of the pelvis, and we try to move insert the camera port at about 2 centimeters next to the midline, so that it won't be exactly at the midline. And the scissor port I would prefer to put it a little bit lower down, so that just in case if the patients have to have upper abdominal dissection, the camera, when we put in here, I can have a broader view of the upper abdomen as well. Uterine manipulator is commonly used during hysterectomy, but then when the patient has a big uterus, it may cause problem, because if the assistant elevates the uterus, it may cause more obstructions of the view. So we've seen one patient with big uterus where we abandoned using the mobilizer or manipulator. And for the uterine manipulator, we usually will use those non-traumatic ones without the intrauterine catheter, at most FIGO. Otherwise, we use mechanical tube more often, where there's no insertion into the uterus. Another trouble is how can we retrieve the specimen? So we have to get it ready during the setup. So we can ask the nurse to have the endo bed or endo catch ready, so that after we perform hysterectomy, we can insert the uterus inside the endo bed or endo catch, and then we retrieve the uterus from vagina, and then dissect it or morcellate it inside the bed. Of course, our pathologists will be unhappy if we cut the uterus into pieces and they cannot orientate the tumor. So if the uterus is really too large, and if we have to avoid morcellating the uterus, so another option is we perform a mini laparotomy, just about 10 centimeter cut, so that we can retrieve the uterus intact from the abdomen. And compare with a big midline laparotomy scar, that will also lead to benefits to the patient. There may be some other troubles that we may encounter during the setup of the robotic surgery. So there's one article published just a couple of years ago, which included more than 10,000 cases between 2005 to 13. And in this series, they use S and SI models, including surgery from different specialties. So the overall failure rate with the machine, either software or hardware, is about 1.8%. And most of the time, it was due to instrumental error. And another study published in 2017. This study included less patients, but it also covered gynecology patients. So the overall failure rate or malfunction rate with the robotic system is 3.7%. And some of the problems was due to the hard drive system problems, and some were due to arm collision. And in this series, they also listed out other problems related to the machine, including like illumination, electronic communication problems, software problems, and also faulty switch. So if we encounter these problems during the setup, of course, we have to rely on our nursing staff who are trained to set up the robot. But sometimes if there are really problems, we have also tried to contact our local agency. And in fact, there's also a service from Da Vinci company, the on-site access, where there's real-time diagnostic tests that can tell you what's going on, and the problems may or may not be fixed immediately. So the conclusion is troubles can arise from patient devices, medical teams, and it can also be related to the operation itself. And prevention or anticipation are the most important. And of course, we also need to have an experienced team, and different team members will play different roles. For example, the nurses will have to check the patient's card, the robot system, lighting, everything. And supporting staff will be important because they have to put the patient into the position. So anesthetists and surgeons are responsible to evaluate the patients before the operation, so that their conditions can be optimized before the operation. And of course, as surgeons, we also have to have a good knowledge about the operation, how it's done, the anatomy of the pelvis, and also we have to know where we put the port, how we design the operation, what to do first and what to do next, and how to minimize the durations of the operation. So this is the end of my talk. So thank you for listening, and I'm happy to take questions.
Thank you. Thank you so much. This was really a practical talk, which I think all of those practicing robotic surgery can use during their problems during operation. So thank you so much for that.